Hello, my coding family. How's everybody doing? Just seeing if you guys can hear and see me yet. Hey guys, just checking to see if you guys can hear and see me yet. Y'all let me know when y'all can. It has been a long week. It has. Yay, good. Okay. Yeah, I just have a common cold, so I'm going to have to try not to talk too much because it'll just start another cough. And I don't want to cough into y'all's ears or snot all over this recording. So I'm going to have to let you guys work on practice questions tonight, and then I'll just fill in if we don't understand a question or the answer or the rationale. But I have the boys dance. Their winter ball thing is tomorrow night, and my mom and I are going to Mexico Saturday and Sunday to do a medication run to get some prescriptions from the pharmacies at a lot cheaper price. So this will be the only time I can go live and do practice questions with you guys this week. So I wanted to make sure and at least try to make it. And if I hit the mute button, it's just because I'm coughing, so just hang back just a second and I'll unmute again. But anyway, let's get started on some practice questions. Y'all let me know if y'all have any questions that y'all want to talk about or have any questions, or you test for your COC on Saturday. Do you do a boot camp classes to prep for the CPC exam? Yes, I do. I do them once a month, and I just did one last Saturday. You can still purchase the replay of the video if you want to, and let me get you the link here. I'll put it in chat, and that's the link to the workshops. I know my next one probably will be in April. March, we've got some things coming up. I'm not sure, but I'm going to try to do a boot camp in March. But the one in April is going to be free for everybody because it's my birthday month, and I want to make sure we have a good one for that month. March, the boys have baseball camp and cheer practice camp, plus a trip to New Mexico with my oldest son. So I'm going to try to do a workshop in March, but nothing's set in stone yet until I get some dates. I feel like I have a cold. I'm getting better though. I'm up and I'm showered today, so that's good. Thanks, Go Kart, for asking. I started my 2024 book, and you like the notes. Thanks so much, Rachel. I'm glad they help. Y'all let me know if you got other questions. The COC, I haven't taken the certification exam. I have done the entire course and, of course, read their study guide. It should be exactly like their practice exam questions. And as long as you've got exam practice questions for COC from exam A, B, C, D, E, and F, and you've done all of those and practiced, you should just do just fine. what I've got up is pocket prep, because I still have 250 questions, or 220, that we haven't gone over yet. Oops, sorry. I of course did that, didn't I? And I don't know why Pocket Prep does this. It drives me nuts. Where's the reset? There we go. I was trying to zoom in on it and make it bigger for you guys, but it's just not going to work today. Might be able to transform it on my side. And make it bigger. It's just slow. And let me go on this side. There we go. It's a little bit bigger. Anyway. This is a good question, because these codes are likely to be on your coding exam, even for the COC people. So knowing how to code these in the back of our book is really important. These 99156 and 57 are often on your certification exams because they are a bit confusing. They want to know, do you know the difference between these codes? And it's just based off of, I think it's the one physician versus two physicians, or staff, I guess I should say. In 99155, the one keyword difference is other. And then 99151, the one keyword difference is same. You don't use these codes with any anesthesia codes in the front of the book. So if you ever see any answers with any of the anesthesia codes from the front, you know that you can eliminate those answers as a correct one. I'm sorry, I'm sucking on a cough drop, so if you hear all that mess going on in my mouth. We cannot use these codes with modifier 51. Is what some of my notes say in my book. What do you guys think is the answer? They have been updating them this year. They put in 250 more new questions. Now we have 750 practice questions, and Pocket Prep did reach out to me and asked to partner after seeing a few of my videos talking about them. And let me see if I can get that link. If you do purchase them, Pocket Prep, we get 15% of the purchase price back to us, which I will use for YouTube memberships to everybody. Here's the Pocket Prep link that is just for Medical Coding by Jen. If you do click on that link, it shows them that my students are interested, at least, if nothing else. And then if you do purchase, we get 15% of the purchase price, which is not a lot, but still their prices are really reasonable. $14 for access to 750 practice exam questions with rationales and page numbers where the answers are. If you do the 3-month subscription, it's $34. And they have a pass guarantee. If you don't pass your certification, they'll give you 3 more months free if you do the 3-month subscription, which is nice that you could possibly get 6 months access to all these questions for just $34, but hopefully you just pass. They have an app that you can use on your phone, which is pretty cool. You could stand in the grocery store aisle and do one question, you know. It's easy on the go. I like it. I've always liked them, even before they asked to partner with us. All right, let's see what B says. That is correct. You did good. And see, you can tell, it tells you what the page numbers are. Come around May 1st, they will switch all of these and change and update everything to 2024 book with the 2024 page numbers. But for right now, they're still answering the questions out of the 2023 book. What do you guys think the answer is for this one? Speaking of YouTube memberships, let's give away some. Go-Kart, Kate, Sophia, Blondie, and Zena all won YouTube memberships. The YouTube memberships will give you access to my exclusive videos, course videos, replays of all the old workshops if they're older than 90 days, access to all the advanced classes that I had, which are called my duck classes. Those are classes that were 2 hours long with advanced tricky questions in them. The workshops are usually an overall of the entire exam. We do 75 questions in 3 hours. I don't know if it's a discount. It seems to be the same price as it was before, Nancy. But yes, you can click on Pocket Prep right now, that link that I just provided you, and you can get access for either $14 month to month, or you do 3 months for $34. We will get back 15% of the money, and they'll send it to me once a month, whatever it is, and then I'll toss it in here to cover giving away all the free YouTube memberships to everybody. If it's blurry, be sure and refresh your settings on YouTube to be of higher quality of display. I am trying to resize it again there for you too on my end. Maybe that's a little bit better. I've got some A's and B's. People are saying A and B. Let's look up our differences quick. 558. What's our differences? Five, 8, 15. Child code, we can't do much with it. We got to go look at Mama. Mama is a prostatectomy. It's under radical also. Good, good. That all looks normal. There is a bilateral factor here with the bilateral lymph nodes. And then if it was A, 45, it's a child. We have to look at our mama code, which is the 40. And you see how its proctectomy is retropubic instead of peritoneal. So the peritoneal was the key word. 45 isn't peritoneal, it's retropubic. Does that make sense? So let's go with B. Perfect. And that's why our answer is what it is. Perfect. Good job. Here's our next one. We have CPT codes and we have diagnosis codes. One of the diagnosis codes is a symptom. Did we never get a full diagnosis? Preoperative, it was a mass. Postoperatively, it turned into a lipoma. That may help you in your decision making for which answer is correct. What do you guys think here? I'm going to check on chat. There's a little settings wheel when you tap on your YouTube video up at the top right-hand corner. If you tap on your video, a little tiny settings wheel will pop up. Click on that. Change your video playback to the highest quality, 1080p, and that'll make it much clearer. You can also transform or transmit your stream to your regular smart TV and make the screen a lot bigger. Instead of watching on a device, you can watch on your big screen TV. $219. $19.25 is a child code. Can't do much with it. You got to go look at Mama. That's 20. It's talking about a biopsy. R32 is an excision. R35 is a radical resection. And R31 is a child code. Can't do much with it. We got to look at Mama code, which is 30, and it's also an excision. The difference between 31 and 32, since they're both excisions, is one of them is subcutaneous and the other one is intramuscular. Did we go all the way down to the muscle? Probably one of those questions where you go through and you look for any AKA terms for the word muscle before you pick sub-Q, because sub-Q will be in both, whether you did muscle or sub-Q. Everybody's saying D, which is 31, which is all subcutaneous. There's no mention of a muscle in here at all. I hate advertisements. D is correct. Good job. Here's our next one. We've got asthma patient. What's our differences in these office visits? We have ER. We have 2 hospitals. And what's our 235? What kind of E&M header do we have for that code? 235 is under what header? That is observation, right? So what was our patient status? Were they in observation? Were they admitted to the hospital? Or were they seen in the ER? Patrice says ER. Patrice says now they are admitted into the hospital. Go-Kart says ER. Nero says observation. Really good question here. Padme says observation. Maisha says ER. If you have my notes on the E&M section, what kind of language or AKA terms do you need to see in the chart to make this observation? The definition of observation can be found in your E&M section. And the definition is really simple. It's just about being reevaluated multiple times during the same visit on the same day. The doctor will come in, see the patient, give some orders, then the doctor will come back in, assess the patient all over again, and either give some more meds or some more orders and discharge, or wait and come back again and do another reevaluation. It's all about that reevaluation. And you can see here on this last sentence that it says continue to examine the patient. If you ever see those words in a practice exam question, continue to examine, which I have in my notes, underneath the 99235, 236, and 234 CPT codes, then you know the patient status is no longer in the ER. They have been admitted as either initial inpatient or observation care. So I bet this one is A. Now they're showing it's ER, hospitalization. Let's see what they're saying. They're saying what? A patient transferred to observation. Oh yeah, they haven't been discharged. I forgot to look for their discharge. Yeah, if they had been discharged, it would have been OBS. This is a direct admit, and they are still in the hospital and have been admitted. They are correct that this is an admission. And we've got references to page number 16 as the answer, but they're correct. I forgot to look for the discharge. I got all excited about continuing examining. He is correct. All right, we've got scoliosis. We have two answers and 205. Let's go see what's going on with those codes. 205. 205. 51. These codes have been on the exam recently. 20550, 551, 552, 553 have all been reported back recently as being possible codes on the exam. So, cool question to have. The 55. Is a placement. 51 is an injection. 20610 is a joint injection. And 270 is way on in the back here. Is also an injection. But what body part are we under? We're under hip and pelvis. If we're under the 205s, we're under general. I do see a joint being mentioned in the question. We are doing it in her. Sac for joint and the fluoroscope is all included in our 270-96. 205-51 are for tendon sheath or ligaments. Were we doing a tendon or a ligament? our 20610 was for a joint, and it's for a major joint. Shoulders, hip, knees. Could be, but it says without ultrasound guidance. Our 77003. It's for fluoroscope. Everybody like B? Good job. Just keeping it clear whether you're in a joint, whether you're doing a tendon, whether you're doing the ligament is super helpful in those questions. Immunizations are always fun. First thing you're going to do is look for your 71 and your 60 codes, because those are a difference whether the patient was given counseling or not during the vaccines. I find it's an easier way to eliminate answers. I don't see any mentions of counseling being done. So it's probably a 71 if they are giving them. Looks like a nurse visit only, just to come back for the vaccines. So probably just an administration fee and the 2 vaccines. I see that 3 of the answers have the modifier 51 in them, and only 1 answer doesn't. I find the 51 modifier strange for immunizations. It's probably nothing that I would code with them. Multiple procedures. We're giving vaccines, but yeah, I like A too. Perfect. Good job. We have a breast mass. So we know all the breasts are done around those 1981 to 83 codes. In my notes, you've got the differences between them. And instructions on how to report them when they're done bilaterally. Two of them start out with 83. One of them includes radiology. We know that the 81 includes stereo. The 83 includes ultrasound. We probably would not use any kind of add-on radiology in these code areas. We just need to know, did we do radiology or did we do stereo or ultrasound after imaging? We did do stereo. There it is right there. So stereo is only done with our 81, right? So probably our answer is this is a practice exam questions for a medical coding certification exam. Just a general one. D is correct. Good job. That's all you had to do looking through all this case is if you know the codes as you're going through the answers and you know what each set of those codes, just what the differences are. Some of them do ultrasound, some of them do stereo. Makes it a whole lot easier when you're going through the exam question not to read all that mess, because your brain will get fatigued. 50 questions in, if you've read all those different words, it's going to drive you crazy by the time you get to the question 51. So only search your questions for just the differences that the answers tell you they are. Hey Melissa, our next live on YouTube will be Tuesday and Thursday next week. Monday and Tuesday will be live on TikTok. I have a cold right now, so I'm fighting runny nose and a cough. In fact, I'm looking for another cough drop right now. I thought I brought a bunch. Here we go. Before today. But I go live Monday through Thursday every week. Barring life doesn't happen. We've got some B's and D's. How does cardiac magnet imaging differ from traditional magnet imaging? It can only be performed under pharmacological stress. I shy away from the words only and never, but contrast can never be used. It is the ability to provide cytological, and it is used static imaging. What is radiology? They usually have all the definitions of all the different radiology things in the radiology section. Yeah, you're going to be able to find it somewhere in here in the radiology section. I'm a-looking. Cardiac imaging differs from traditional imaging because they don't use any ionizing radiation. Is that a possibility in here? What's she saying? First sentence of the paragraph, page 547. Magnetic imaging index in the heart, and it leads you to that code. And the first sentence of the paragraph says, cardiac MRI studies may be performed at rest or during pharmacological stress. MRI relies on static imaging to obtain clinical diagnoses. So we've got C, right? They have a strike through thing here that you could do, which is kind of nice. They're saying it's the ability to provide psychological evaluation for heart function. Physiological, not psychological. And yes, they say it's right here on that page, 535. Oh, I love these codes. The 644s, 90s, they're so fun. All your answers will be based off of your parentheticals. We've got 1 level, 2 level, 3 level, 4 levels here being done. So you'll have to rely on your parentheticals to work on this question. You get rid of your A, your apprenticeship, by submitting your college transcripts or any transcripts from any medical coding course that you took, even your AAPC certification, if you took and passed a course through them, submit that. I submitted records of an associate's degree back from 1994, and they accepted those. I also submitted a letter from a coworker saying they've seen me utilize ICD-10, CPT, and HIPICS in my daily duties while on the job, working with them for over a year, whatever, and submitted that as a PDF. We used to submit them through email, but now there's a particular spot you go on to the AAPC website and you upload those 2 documents. See if I can find the link here. Okay, got the link. There's the link you can use to go to the dashboard where you submit the information to remove your apprenticeship. Yes. If your nursing college included any courses in ICD-10 CPT coding, which most of them do, then that's perfectly acceptable. You can get an informal copy of your transcript, save it as a PDF, and upload it on that dashboard. Diploma doesn't work. They need a list of the classes that you took. So the list is on your transcripts. Certified medical assistant, yes, it should work because you've got coding classes in the medical assisting course classes. And you just need your unofficial transcripts, which will list out all those classes that you took. The certificate or diploma won't help. You need the transcripts. Even if your school closed, there's a transcript warehouse you can go to, pay, and get a copy of them. Perfect. Just upload that. It's okay. Mine was in 1994. You know it was on ICD-9. That's fine. It doesn't matter. You're saying, everybody's saying it's answer A. We have 4 levels. 3 of the answers have radiology in them. Only 1 doesn't. It's another observation I found on this question, making it a little too easy. We know we don't add radiology to these, and 3 of the answers had radiology added onto it. Look at your differences between your answers. We've got a critical care, and then these answers are divided up by patient ages a lot of times, especially these 2. And then we have a standby visit for E&M. What did we do today? Patient is admitted into NICU. Then they do vent management and an echo. What would they bill today? Remember, once they're admitted to NICU, it's a global thing. Yes, I would submit it all to AAPC because they may take your medical terminology and add that to your medical coding credit. It's really hard to get a whole 80 hours all in medical coding, but they may take some of your other classes and let it add up to 80. So yes, please submit that. Sophia, I know I didn't have 80 hours in medical coding, but I had A&P, Anatomy and Physiology 1 and 2 for my nursing degree, and they still accepted all mine. So, absolutely. Let's see if you're correct. Good job, Patrice. Melissa. Yes, it is C. Perfect. Good job. Lab and path. We see the 32 modifier and the 25 modifier might be things to keep up with. what's going on in the 803 area. So all the answers are around the 803. They want to know if we know the difference between 75, 76, and 77. And if we would use a modifier or not. What do you guys think? Y'all are thinking mandated? 7 or more? Here's your next one. Sophia, are you clearing your headers before your descriptors when you're doing your questions for your exam? Or are you just running from code to code? Let's see. Okay. So if during your exam you're getting 4 different answers, right? 2 sets of codes might be here on this page, and then 2 sets of codes might be here on this page. Are you running just to the codes and looking at the descriptors, or are you clearing headers first? The header for anything on this page being coded is lips. Anything on this page that's being coded, half of it is on pancreas. The other half, if it's up here, you have to look back for a header. And it'll be in red font. We're bilineary track. Are you clearing these red headers? Is your question about lips, bilineary tract, or a pancreas? Before you look at CPT codes and their individual differences, clear these headers, no matter what section you're under, before you look at the CPT codes. I'd say if I'm here and 2 answers are on this page, and then I've got 2 answers on this page, what are my headers first? Over here on this page, it's legs, tibia, and fibula, and joint. Here, I'm under nose. Yes, I'm under the respiratory system and nose. Is my question about a tib, fib, leg, or ankle, or is it about noses? That's how you get better accuracy with your exam. So now when you're going through and you're doing practice exam questions, before you retake your exam again, don't do them based off differences of the CPT codes. Practice looking at them for the differences in their headers first. Accessory sinuses versus nose. That's a big difference. If you're only doing the accessory sinuses versus a nose surgery, do you know the differences? What is an accessory sinus? Did you list out any optional words for what that might mean? Those kind of things. Fix your headers. Make sure you go through and you notice where they're at. And now when you go back and you redo practice exam questions, start by clearing those major headers first. Then eliminate, like I know I'm not doing noses. Yes, I'm doing accessory nasal polyps or something. then you can narrow down your answer to a better 50-50 shot. I hope that's helpful for you, Sophia. Sorry, I'm not feeling 100% well today. I've got a cold, but it's not major. Let me get this camera off. Oops, wrong one. But that should give you some focus, Sophia, on where to study and how to study better for your next attempt, for sure. Okay. Yes, you really should have DEC, and also, let me show you something else. Hold on. If you're on the AAPC website and you're looking at your failed scores, do you know how to get to this area inside your account? You're just going to go to My Account, and you're going to go to your exams listing. And if you haven't failed, if you failed one, down here at the bottom, let's see if I can't get this to fix. Oh yeah, I got it locked. There we go. Underneath your results from that day, you will see this area of practice sample questions. I recommend buying all of these if you can afford them, but that's like $500. It's really expensive. It's really expensive, but if you can't afford that, go here to this tab and it'll sort out which ones you scored really low in. Like right here, coding guidelines, if you scored really low in that, you could buy just those questions. That's $30 for 20 questions. It's super expensive, but guidelines are 9 questions on the exam, and that's a higher threshold than like if you missed hit picks. There's only 3 questions on the exam. I wouldn't spend $30 to get 3 questions right. I wouldn't do that for the hit picks. So go based off how many questions are there in each section. If you scored low in lab and path, get those. In E&M, get those. That way you're not spending $500, but these questions are super helpful. If you can just select the ones that you scored lower than 70, it would be all of those. It's a lot, but it's expensive. But right underneath your scores is where you buy the area of study questions. Those are super helpful, but they're super expensive. I have them purchased for you guys, but not everybody can do that. They're really expensive, but if you can, get the E&M and get the guideline ones if nothing else. And then maybe just one of the musculoskeletals or cardiovascular if you scored low in those. That'll be $100 or something for 3 sets of 10. And then, of course, get exams A, B, C, D, E, and F. D, E, and F are way more challenging than A, B, and C ever were. Those are really good set, D, E, and F. I did say definitely more challenging. The exam questions on D, E, and F are more challenging. They are. And the ones in the area of study are very challenging. They are. The cases in lab and path are really low. If you made 50% in lab and path, that's a passing score for me. So don't stress too much about lab and path. It is a very, very difficult section. But if you did score, 10 or 20% in lab and path, then yes, get the extra questions for sure. How do you get the questions on AAPC to practice? I'm just on the AAPC website, and I go under a test exam or a certification exam that I failed. I like to go in and do each exam twice because you pay for 2 attempts, and I like to see the certification exam twice so that I can help you guys out anyway before I pass. And if you just go under your scores, let's keep scrolling down. They have this whole section where they're trying to sell you extra courses and extra practice questions. I stay away from the courses and just go to the individual test questions. And 30% on the cases. I don't think they have an option to buy cases. They just have the E&M part. You can buy 20 extra questions there. I like the compliance and regulatory coding guidelines, the E&M questions, cardiovascular, and the 6,000 questions with the nervous section in it. It's really good questions too when you're doing area of study. Yes, you have a year to take the exam from the date of purchase. Okay. For this pocket prep question, what did you guys think the answer was? C? Somebody said C. And if anybody wants sometimes I feel like the headers don't even make sense. Body parts, they make sense. Are you in the nose, the arm, the leg? Where are we at? Makes a little sense. Everybody's saying C. Perfect. Good job. 3,000s, 336s, 41 or 47 or 45. We in respiratory or we cardiology? Cardiology. Three, 336. This one has a blue header over 41 for septal defect, and then 45 Good, same header. 47, same header. And 75, same header. 75 is a closure. 77 is a repair. 45 is a patch. And 41 is a repair. What did we do today? We did a repair. Would you diagnose the kid with a symptom and a diagnosis? They have a septal defect. Would we do the R code with it? Or would it be the Q code by itself? Q codes are genetic deformities. Would you have one diagnosis versus two? How many defects did we have? Looks like there was a defect noted in this area, and then they had a second hold in generally the same area. Both holes were closed together with a single patch. "75 says multiple defects, where 71 says septal defect. One is ventricular septal defect, the other one is cecum. The kid is on bypass 2. One of the codes says something about a bypass. Perfect. D is your answer. Don't pick the answers with the symptoms, with the diagnosis. You can eliminate those really quickly. This one, they were trying to confuse you about the multiple holes. Good question. We have how many levels here? We've got 1 level, 2 level, 3 levels, posterior. How would we do 3 levels? I'm not sure, Tamara. You're taking yours tomorrow, Mom? Oh my. Let me look in my notes real quick of stuff that people have said recently. Okay, that's going to change that. I can't do that one. Um, what do you guys think is the answer on this one? A's and B's. Got pretty big differences in a lot of these answers. Are you in the 226s or in the 225s? Two, 5, 30, 3. Lateral extracavity approaches. 554 is under anterior approaches. Are we lateral approach? Are we anterior approach? Where are 226s, 12, 226, 12, and 30 are under posterior approaches. A really good question, where A is lateral, C is anterior, and D and B are posterior. How is our approach into the patient's body? Posterior. Did we do the laminectomy, discectomy with an arthrocentesis? We got the discectomies and laminectomies were carried out. Perfect. Sounds good to me. Perfect. Good job, guys. Figuring out your approaches and then figuring out what exact procedures were done makes that question easy peasy to decipher. Are we doing low, nurse visit, new patients, low or minimal with this particular situation? You have 3 elements with E and M. One is your problem list. What's the problem list? It's nausea, which is minimal. We have recommendation for medication, which is our risk, which is moderate, even though it's over-the-counter meds. Our risk, or our data that we reviewed for today's visit, is none to minimal, because we didn't do anything as far as x-rays or order any blood work. We have to match 2 out of 3 for established patients. You have to match 3 out of 3 when they're new. The only 2 that we have matched is the data and problem list. Just depends on what you recommend the nausea being. Is that a undiagnosed issue? That undiagnosed issue with uncertain prognosis could be a moderate. What do we consider nausea to be? Or is it an acute, uncomplicated illness or injury? If it's that, it's low. Because we have one moderate, the moderate also includes a low and a minimal in it. So it just depends on what we consider that diagnosis of a nausea. Would it be a self-limited minor problem, or is it an acute, uncomplicated illness or injury? How do you classify nausea? Oh. It's a self-limited minor. Everybody's saying A. Let's see what it is. It is A. What did they consider it? The nausea is a self-limited minor problem. She is pregnant, which gives us a low dose. They gave us an OTC advice, which is moderate. I know that much. But because our data was 0, that bumps it down from a moderate to a low. No data. They're saying it's not 211 because the patient did see a provider and had an exam. They're not considering that to be a nurse visit only. On our integumentary here, we have 3 codes in integumentary. One of them, is that I and D? No. 61, not 21. Yeah, I and D. And then our 1-1s are under debridement. Those are under debridement. And then our 5-6s are under male genitalia. What did we do today? We did debridement of external genitalia. They consider it drug management when you tell them to take over-the-counter meds. It's crazy, isn't it? After reading the question, I'm nauseous too. Yep. Medications, even over-the-counter, come with inherent danger. You don't know what they're combining it with. They consider that to be drug management, and they will always consider that to be moderate. I always levy it against all the other factors. If they are given OTCs, I always bill a low, just for a medical coding exam. If they are given the patient real prescriptions from a pharmacy, it's always a moderate. But just in general, if they say OTCs, I always bill low. Yeah, OTCs is considered still drug management, and that one particular part of your MDM is still considered and billable for moderate, even though the doctor gave them an over-the-counter med. But there's 3 elements to billing an E&M. When you're not given time and you're not given the MDM by the physician, and you as a coder have to figure it out yourself, there's 3 parts to it. And OTC is drug management. That's moderate. But the problem list is where we come into knowing this is a minimal self-limited problem and there's no data. 2 of your 3 elements code at a 99212, right? Or, yeah, 12. Which wasn't an option for us. Our only option was nurse visit or low. Technically, it should have been billed as a 99212, but whoever wrote the question, has a particular answer that they wanted in line, and they wanted the 213. We didn't have the 212 to pick from, which would have been the correct answer, but we know it's not a nurse visit, and that's the 211. So we had to go with the low. Poorly written question for a clinical exam where you want to see right and wrong in front of you. So I see your point. For sure, it should have been a 12, but that wasn't our option. I hope that makes sense. Yay, you can get your books. Is 1104 for dead tissue? Yep. Okay, good. Perfect, guys. Good job. That is correct. Diagnosis code. Patient is diagnosed with, I'm not going to pay attention to the rest, just this. How do we code that? Is it I-20 or I-25? Look at your 2 differences between I-25, stop there, and your I-20. Figure out if you're this set or that set. And then you can go down and see your differences between your individual code differences. Once you figure out where you're at there. Good job, Aaron. I usually correct a lot of codes with Pocket Prep. I need to question them on that one and have them reconsider. Technically, for 2024, the answer in question should be updated, and I'll get with them on that one. Everybody's saying A. Good job. Perfect. Hernias. We always need more practice in the hernia area. So let's go to those 946's codes real quick. Nine, 4, 6, 13. Is reoccurrent. 21. Peristonal. 23. Is an add-on code and can't be coded by itself. And then 591 is abdominal hernia. What did we do? Everybody likes D? I do too. Good job. Perfect. Differences between all these codes, I believe, is patient age. I know for some. Can you get to all these codes? Can you even find all these codes in your CPT book? A lot of people have a lot of trouble with these codes, not being able to find them. This is newborn to 21 days, something like that. Oh. 66 is our critical care. For transport, it's hands-on during transporting patients. '68 is newborn to 28 days. 79 is the subsequent hospital intensive care management for premature babies born 3 to 5 pounds. 77 is an admit into the hospital for 28 days and younger. A baby was admitted to NICU for respiratory distress and critical care services earlier the same day the newborn was admitted to the hospital by the same physician. No newborn care was administered. It says earlier the same day the baby was admitted to the hospital by the same physician. And it says here that a critically ill newborn was admitted. So if this admission was for the critical care, that's our 68 code, but that happened earlier in the day. Now we took this critical care patient and we provided critical care services. Is that a subsequent visit on our critically cared patient? Or did we re-advance and then readmit them and move them to an intensive care unit? And do we get to bill for 2 admits in one day? We have an admit into critical care same day, and then we have an admit into intensive care same day. Or would this be a subsequent visit? Or do we get to bill for subsequent visits on the same day in critical care? And do we get to bill subsequent encounters? It does say on all of these they are per day, so they can only be billed per day. Did the same doctor already bill for that? I would assume earlier the same day the patient was admitted to the hospital by the same physician. That will start an admission, right? Then we took that critically ill newborn that we probably admitted into critical care and admitted the baby to intensive care unit. If you look at your codes, there is a difference between intensive care units and critical care units. There's a set of codes for both. They're wanting to know if you know what to do if they're both billed on the same day. What do you do? When a neonate or infant becomes critically ill on the day when initial or subsequent intensive care services have been performed by the same group, report only initial or subsequent inpatient neonatal pre-care based on the patient's age, is what one sentence says here. So would we bill just a subsequent visit? Can you bill an admit and a subsequent visit on the same day? When a critical care neonate improves and is transferred to a lower level care, we do one thing. What about when they become critically ill? When a neonate infant becomes critically ill on a day when initial or subsequent intensive care is performed by one individual and transferred care to the provider for a different group. We need the same group. Oh. But critical care and intensive care provide different services, and they have different pay rates too. Only report the initial or subsequent, right? Trying to find the right guideline in all this mess requires a initial critical care service on the same day and has already received hospital care or intensive care services by individual group. Only the initial critical care service is coded. When a neonate child requires initial critical care services on the same day, the patient already has received intensive care services. Nope, that's not what this kid has. This one started out with critical care and is being increased to intensive care. But this one, that one guideline says just bill the 68. If you're going to bill the 99477, it represents initial day of inpatient care for a child who is not critically ill but requires intensive observation, frequent interventions, and other intensive services. So if we're going to use 477, it has to be not a critical care patient. According to that guideline, probably a different book. I'm in the 2023 right now. Let me look at 2024. 47, page 3. Third paragraph from the bottom. When a newborn critically ill on the same day, they have already received normal newborn care. Same individual group, blah, blah, blah. Yeah, that's not helpful. Critical care services provided for neonates. Critical care proves and is transferred. No, we don't want improves. Subsequent, we want them to get sicker. Yep, we're just going to bill our routine 68. We can't bill 77 if a patient is critically ill. All of that would have just been related to just the initial critical care admit. Awesome. Good job, guys. Did we do an admit and discharge all on the same day? Did we just do an admit? Did we do subsequent care? Or did we do a consultation? They were admitted yesterday, being seen for follow-up the next day. I had them change this question. They had it wrong. So this is one they corrected. So we're just going to match our high level. Which one of these has the high level MDM? We know our admit doesn't, right? Our 3-4 is a straightforward or low. That also too doesn't match. And our 2-5-3 is also a low level MDM. So all of those are all low. The only code with a high MDM is C. Even if you're not sure what type of visit it is, always check when they give you the MDM. Go check all the codes to see which one is actually the overall MDM, and that may help you out a whole bunch. Good job. Oh, God. Whew. Okay. We got a lot of 5-4-0s. Let's go to those. Oh. 65s. It's destructions. Did we do simple or extensive? What's our differences between those? Would we use the 59 modifier? Would we use the 22 modifier? Do we times these codes? Do they have the word each inside of them or not? That determines whether we use the times or not, right? So the only code without times is the only code without a modifier. Yeah, 12 lesions, all in that very simple area. Would you consider that extensive or something simple to do? I'm sure there's a definition somewhere of what's extensive, which is how are you on the wrong live? I'm only one person, girl. Okay. What did you guys think? Y'all think it's C2? Perfect. That is correct. Sometimes it's just fun, even without looking at the book, to try to think what the answer might be. Can you find these codes? Do you know where they're located at? What's the differences in them? What are the only differences you need to look for in the question based off the codes? So we're 993s. I think these are all age-based, right? Newer, established, and then age-based. So we can eliminate a lot of things. So we got 394. Oh, these codes are horrible to find. All right, 94, 84, and 85. New are the 8s. Is she a new patient? She is a new patient, so we're going to keep her in the 8s instead of the 9, so we can slash through that one because she's not an established patient. The difference between 84 and 85 is just based off age. That's the only thing we need to look up. We can't bill an 85 because she's not 18 yet. So the 411 is preventative counseling and risk factors, but under a group counseling setting. Is she in a group of other patients? Is she in a group? Since she's not in a group, we can get rid of that one too. Perfect. Good job. A meniscus tear. Oh, these are always lovely to do and will be on your exam, and they can be very difficult because the route in the body can be medial, lateral, but the repair is also done medial or laterally. So you have to really be careful with these. And sometimes the name of the surgery does not match what they actually ended up doing. You have to verify what they actually did in the note, not just go off of what's up here sometimes. So our differences between these codes is or and. Did we do a repair on both sides of the knee, or stitches on both sides of the knee, or did we do just one stitch on one side of the knee? Let's see, 98. 988. Both sides is 80. One side is 81. Would we use it with the combination of the 22 code? What did we do? It says up here preoperative, they would have done this with nerve stuff, but here it says they did this. Medial had a flap fixed. Lateral had debridement. Lateral compartment was debribed. Lateral was and probed and found to be intact. Loose cartilage along the lateral, debribed with a shaver, and then it was irrigated. we did horn flap tear repair medially, and we debribed the lateral side. Did we do anything with the nerve? If we did the synviscous, that's usually coded with like a 29875. It's usually not coded with anything else. And yeah, the 22 is for a different body part. Humeral bone, humeral, cartilage biceps. Yep, those are shoulders. So it's just a difference between this. I don't see that we did something like that, but some of those are coded with an additional code. If we did that, the nerve removal, it would be up in the 75s, but now you just have to know if you did an or an and. We're split in the middle. We've got 2 A's, 3 A's, 3 C's. It's a 50-50 shot, huh? If you look at your descriptor of 29880, it says including shaving, debridement, and cartilage stuff. So if it was or, if it is the 81, we would have not done anything on one side. And if nothing else, we saw that we went in on the lateral side and we shaved on both sides, right? We did a stitch and repair on one side, and then we went into the other side. The lateral compartment was inspected, was probed, and to be found intact, but loose cartilage along whatever was debribed. So in the descriptor of 80, it says including debridement. So it looks like we did something on both sides. So knowing fully what's going on, it's not just stitches. So debridement, whatever, if we did any of that, I believe it's going to be A, right? Yes, you can see the top again. And see, the top just says we only did medial. And then it says a nerve removal of the right knee. If we did a nerve removal, we would have had to have built a 29875 or 76, but I don't even see. Was resected. They did do a hypermedial nerve here. I don't even think their question is right, but maybe they're only asking us which one should be reported first. The first code would be the 880. Second code would be our 75 for our nerve removal, but you know, what do I know? maybe another question I need to ask them about to make sure that they've got it correct. But we did go in on both sides. They're saying it's this one for a shoulder. Oh God, I'm gonna have to talk to them, huh? What is this? Yeah, they have the wrong code for this, don't they? And see, it says in their rationale 7.5 right there. Should be reported for that nerve. That's the one I was telling you about. But then their answer up here has the 22. So that answer is not correct. I gotta talk to them about this one tomorrow. So that's why I wanted to go through these. I have to go through all of them because I do find errors in them. And these are the questions I haven't gone through yet. And I want to make sure that I know with you guys we'll find the errors. Let me just take more pictures and then I'll get this to them tomorrow to fix. Even their rationale says what the right answer is supposed to be. They just, you know, it's humans. Humans make errors, so I even do that. So anyway, I'll get them to fix this one. But it would definitely be, we do code both. See, it says right here, we did do both. And we did the nerve removal. So their answer should have been the 80 with the 29875. They don't even mention, let's see, the debridement of the lateral and patelliformal components, therefore, is reported with 28922. Is patella mentioned in that 22? Is patella mentioned at all? We've got humeral bone, humeral cartilage, cartilage, bicep, anchor, labrium. Is there anything that mentions anything about a patella cartilage? It still all looks like shoulder to me, doesn't it? Knee doesn't start till 29866. Debridement of a knee is 29877. If they wanted to build just with an additional code, 29877, but interesting, but I'll send it to him tomorrow. Yeah, that's shoulder. You bill it all the time on your own. It's a chondroplasty. You do orthopedics. chondroplasty is included in a meniscectomy. That's what I thought. That's what it says. The CPT code descriptor for 29880 includes debridement. It shouldn't include any other code. It should be the code by itself. 29880 should be the answer because we went in on both sides. We stitched one side, but we did debridement on both sides. And it includes a chondroplasty inside the 29880. It's all included. Yes, and if they had removed the nerve, which they said they did, it should have been the 75, should have been added as a secondary code with it. And they didn't even mention it. 76 is for 2 or more nerves that were removed, but it looks like they only did 1. Yep. Thank you, thank you, thank you. 822, but it doesn't matter whether it's a chondroplasty or not. It's not. It's for the shoulder. We're not in the shoulder. We're only in the knee. I'm sorry, I'm coughing in y'all's ear. I couldn't get to the mute in time. Hold on. Okay. Making marks in my book. No worries. Yes, 29877. Yes, the 77 is a shave or debridement. It's a chondroplasty. If that's all we went in and did on the patient, you can just bill for that. If we didn't go in and do a meniscectomy, fix the meniscus, we didn't do any stitching or repairing on one side or the other, and we only debrided on one side of the knee or whatever, you can bill a chondroplasty by itself, and that's the 92877. I'm not sure what they were trying to do with that question. It looked like they really wanted to bill 2 codes with it, but the 2 codes they were billing shouldn't have been for the chondroplasty. It should have been for the synovectomy, because the nerve removal is something you can bill separately, and I think they just put the shoulder thing in thinking it was for the nerve. I don't know. Somebody wasn't paying attention when they wrote the question. And it's hard. When you write words, you see them as you think they are, and until you present them to other people and read it from another person's eyeballs, then you can't see your own mistakes. I do it all the time. I think I know what my questions say that I prep for you guys, and then I get down to doing them, and every so often, of course, I'll have questions that, oh, no, I wrote that totally wrong, and I was thinking it was saying the correct thing. I just couldn't see my mistake with my own eyes. I have to see it through you guys' eyes to find my mistakes, and it's just part of being human. Our minds play trick on us. Our eyes lie to us. Our brain lies to us. It's one of those things. Everybody saying B? Y'all got 53 modifier in, what's 53? Discontinued procedure? It wouldn't be 73 after anesthesia was discontinued, outpatient after anesthesia was administered. I like 74, but went into shock due to surgery and the procedure was halted. Sent to the recovery room. I think the modifier should have been 74, but I don't know. All right, 53, 47. 47 is anesthesia by surgeon. No, we don't do that one. 51 is multiple procedures. No. So I guess the only one that could be is 53, but yeah. '74 would probably be a better answer, but yeah. All right. B-scan. What is the B-scan? You know, the definitions of all these are in the radiology section somewhere. There's a page that defines all these. Under ultrasounds, I think. It'll be in your CPT book in the radiology section. Our eyes lie out, they do. Yep. Our eyes do lie to us for sure. What do y'all think? Page 544 in the 2023 book. It's got B-scan, M mode, A mode, real-time scan. And in the 2024 book, it is in here. Maybe they took it out for the 2024 book. Did they take out those definitions? I don't know. Oh, there it is. It's on page 556. Yeah, there we go. It is our B scan is 2-dimensional ultrasonic scanning with 2-dimensional display. Be sure and don't pick the one that says motion and time. Percocet. Are we in an hospital admit? Are we in the ER? Another hospital admit or an ER? Do we have an MDM? We do have a low-level MDM. So match your visits. Which one is low-level MDM? I think our 94 and 95 are both not low for ER. 94 is moderate, 95 is high. We know our admit hospitalization. 21 is straightforward or low. 22 is moderate. The only low level one we have is C. Do you see how 21 has 2 MDMs? It's straightforward and or low. And our 22 is moderate. Did a lot of moderate medication. Dehydration, adverse reaction. Just need to match up your MDM. Good job. 6,000s. We'll do this last one and be done for tonight. I'll be back on Monday. We'll do 2 hours of book prep on TikTok. I hope to see you guys there. I'm sure I'll be feeling better by then too. What's going on with our 615? We got 2 with 645 answers. 2 of them. 645. Remember, if y'all want to play around with these pocket prep questions too, if y'all purchase from our link that we were given, we get 15% back. And it's $14 a month for access of 750 questions with rationale and page numbers where answers are, or $34 for 3 months access with a pass guarantee. They say you'll pass. And if you don't, they'll give you 6 months free. So anyway, we get 15% back once a month if you do purchase these questions. And then we'll give those out as YouTube subscriptions. Speaking of that, let's give out another membership while y'all are here. For the people that have stayed so long with me tonight. Are we 64553. Let's go look. 6455. Brittany, great. I hope those access to all that workshops and practice exam questions inside the duck classes help out a whole bunch. A lot of advanced questions in those areas. Are we in the peripheral nerve? If we are, we're near the 68. Vagus nerve. Do we do an open procedure or percutaneous through the skin? Not really telling us how they went into the body, but they are telling us how they closed the body. '68 is open implantation near the cranial nerve. 53 is percutaneous through the skin. If you pick 68, we went open into the body. '53 is through the skin. '61531. We're under skull, meninges, or brain. We did burr holes into the brain when we did that. The header above these is extracranial nerves, peripheral nerves, and autonomic nerve system. '53 says we attach this to a cranial nerve. '58 says vagus nerve. We have vagus nerve here. But it says that today we underwent a procedure to implant cranial nerve, which was coiled around the vagus nerve. What do you do when they mention both? Today we did the cranial nerve. Everybody going D? Did we do an electro array with a pulse generator? 68 has a pulse generator with it, where 53 is just the neurostimulator electrode. What did we implant? Underwent a cranial array right there. The pulse generator was connected to the array, tested and repositioned for maximum efficiency. Pulse generator was placed and sutures into a created subcutaneous pocket. Again, the system tested for proper function. Did the patient already have this already implanted in their head? History of epilepsy, seizures, tolerated medication management, did not experience, which confirmed. Today he went open, an open procedure for an implantation of a neurostimulator array. And it looks like a pulse generator too. '53 is just the array by itself. This one also includes a pulse generator. '68 is correct. Good job, guys. It looks like they're really trying to make you pick just the array itself by what they said right here. But it does have the word open, not percutaneous, and it does say that a pulse generator was placed and sutured into a subcutaneous pocket. So it does include the pulse generator. 53 does not have a pulse generator. I hope that's helpful, guys. And oh my gosh, to whoever is taking their exam tomorrow, I can't remember who that was. I wish you the very, very best. I hope everything we've ever gone through makes a big difference for tomorrow and you pass your exam. I really will be thinking about you tonight. I hope you pass for sure. The boys have a dance tomorrow night, that winter ball that I thought was on Valentine's Day. It's actually tomorrow night, so I'll be parking lot guarding the boys for this dance. So I won't be able to make up the live tomorrow. Saturday and Sunday, going to Mexico to get some medications for my mom. It's about a 4-hour drive one way and back, so we'll spend the night down there, I think. And then, so that won't give me any chance to go live again until Monday for TikTok. So I hope you guys have a great rest of your week. And I hope everything was helpful, and I miss you guys and love you guys and so proud of you guys for all your hard work and working together on the Discord with everybody and answering questions and coming in there with your questions and posting them and letting people help out and try to answer them. It's super helpful because it builds up their skills and yours too when you do that. So I really enjoy seeing that. Be sure and check out my website. I've been altering it and adding more things to it. Look in the resources tab. Look in the practice area. I'm trying to write code so that I can invent questions. I've got 2 up so far, but it takes a lot to write code to do them that way, but it looks a lot better than the system that they gave me with the Wix website. So I really like it, but it just is a very slow process to write code for every question. but I'll get it done one way or another. Anyway, y'all be sure and check it out. There's quite a bit of new stuff there. There's a new YouTube video I posted up of the nervous system book prep. I finally got through, probably a halfway through, an hour into it, answering people's questions, and then really actually started doing book prep on the nervous system. So go check out the last hour on that. I just posted it today. I hope all this is super helpful. You're welcome. You're taking yours on the 28th. Coming up soon. Thank you, guys. Yeah, I can tell you how to find the TikTok for Monday. Let me get you the link here. Everything's under medical coding by Jen. There's a ton of TikToks already up, of course. Here's the link for the TikToky. Just click that link, it'll throw you in there. We'll do 2 hours of book prep, 6:30 Arizona time. You taking your test on the 16th. Got to get it scheduled. Awesome, Rachel. I hope you do well. All right, guys. Love y'all. I'll see y'all on Monday.